Okay, good afternoon or good morning, everyone, and welcome to the SDOH Academy's national webinar series. You've joined us on part 3 of 4, being held on February 1st, 2024. Also, happy Black History Month. We look forward to celebrating with you. On today's webinar, we'll be discussing building bridges between healthcare systems and community-based organizations to address health disparities. My name is Bethany Hamilton. I'm with the National Center for Medical Legal Partnership. We are one of the national training and technical assistance partners that are members of the SDOH Academy bringing you this content today. Welcome, everyone. Let's go to the next slide. And as folks log in, just know that we will be making our way through an agenda. First, we'll go through some introductions and housekeeping. We'll introduce the guest speakers for today, and then we'll leave ample time for Q&A throughout the duration of the webinar and certainly at the end. So at any point during the webinar, please feel free to use the Q&A function to share your questions, and the chat should also be open for engagement. So please continue to engage throughout the webinar. We'll look out for those questions as they come through. We'll also make sure that everyone receives access to SDOH resources. Okay, let's go to the next slide. All right, so housekeeping, as promised, you are joining today's webinar on mute. And of course, that's to keep down on the background noise. But again, we encourage you to use the Q&A function and use the chat box to engage, submit questions, as well as any comments. This webinar is being recorded. We know people want to access those slides and materials that have been shared, especially by the subject matter experts from the field who are joining us here today. But we'll also help you out by sending an email. If you register for this webinar and you're attending, we're going to send a follow-up email to ensure that you have access to that posting. We'd love to hear your feedback as well. So if you've been joining us on the other webinars or any of these NTAP webinars, you know that we do want to hear from you through an eval. So we're going to share a survey link so that you can let us know how we did and how we can continue to improve our resources. Let's go to the next slide. All right, so as mentioned, this webinar is being presented by the Social Determinants of Health Academy. We're HRSA funded. We provide virtual trainings and other resources to really help health center staff, as well as PCAs and HCCNs, develop, implement, and sustain those social determinants of health strategies and interventions that will help their clinics and communities. The power of the SDOH Academy is that we don't just focus on any single intervention. We bring together our expertise as HRSA-funded NTAPs to work together to offer a really coordinated curriculum that we continue to improve upon and assess for future revisions and improvements. And that curriculum is to assist with multiple community-based SDOH interventions. To learn more about us, we hope that you will visit sdohacademy.com. That's where you can find the recording from this webinar, as well as our past resources and content. Let's go to the next slide. As NTAPs, or National Training and Technical Assistance Partners, we're really trying to help you all from the health center field really improve the impact of your health center program. We hope that by producing this content, we're helping you increase access to high quality comprehensive care for underserved populations. We hope that we're supporting HRSA awareness of issues impacting health center and special populations. We're helping to support health centers in the identification and implementation of evidence-based promising practices. And we hope that health centers ultimately will be able to leverage the shared experience and data to improve health outcomes for patients around the country. All of our work as National Training and Technical Assistance Partners can be found on BIPIC's website. So again, this hyperlink will be shared. It's been shared in the chat. Please feel free to explore what the entire NTAP bunch is getting done by visiting that webpage. Let's go to the next slide. Again, multiple NTAPs are involved in the SDOH Academy. You can see based on our logos who all is involved, and we are growing. So stick with us as we continue to grow and evolve. We will continue to improve upon our work, and hopefully and ultimately that improves the services and care that health centers are able to provide for health center patient populations. Thank you for joining us. And we are very proud of the National Center to be able to work alongside and in collaboration with the NTAPs. Let's go to the next slide. let's launch a poll. I noticed that at least one audience member has raised a hand. Please feel free to send us a chat so that we can assist you. But let's run this poll first. So the first poll question, we want to get to know who's joined us today. So tell us what type of organization you're joining us from. Which of the following in the list best describes you? Are you from an FQHC? Are you from private practice healthcare? Are you a PCA, another NTAP, a health center controlled network organization, an HCCN? Are you from a government agency, whether federal, state, or local? Are you from an academic institution, a social services organization, or CBO, an advocacy organization? Perhaps you're a legal services provider, a law firm, or if you fall into the other category, please, please, please leverage the power of the chat and let us know. Just feel free to send a chat to everyone so that we can get to know who you are. So about 72% of the folks have already responded, and we know we have a lot of people actually still trying to join us, and we'll go live stream as soon as we can. But for those who are able to respond, I'm going to end the poll so we can see the results. And about 40% of you, and we have definitely over 500 people joining us on Zoom and 1,200 that registered, but for those of us who are on Zoom right now, about 40% of you are from health centers, 4% from from private practice health care PCA. We see your representation. Thank you for joining us, as well as other NTAPs. 16% of you from government agencies. Great to have you all join us, along with the folks joining from social services organizations, legal services, and other advocacy orgs. Didn't mean to leave anyone out. Just wanted to highlight as quickly as possible who's joining us today. And it's lovely to see folks who are falling into the other category, including our MLP friends and our MCO friends, are letting us know who they are in the chat. Thank you so much from the nonprofit hospital bunch that are joining us today. All right, let's move along. So I'll quickly go over learning objectives, and then I'll pass things along to my colleagues to carry us into the actual content for today. So after this webinar, we hope that folks will be able to better recognize how those social determinants or drivers of health impacts health equity and access to care. We also hope that you'll be able to explain the importance of building and sustaining successful partnerships that are community-based between health centers and other CBOs who address SDOH. And we finally hope that you'll be able to specifically identify those innovative strategies and resources for SDOH screenings, and then best practices to build effective SDOH-based partnerships. All right, let's get ready to learn. I'm going to pass the mic along to our colleague, Matt. Matt, all yours.
Thanks, Bethany. On this side, you'll see an overview of social determinants of health. What are social drivers of health? Are conditions in the environment in which people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and life outcomes and risk. It's a resource that could enhance the quality of life or diminish the quality of life and significantly influence population health outcomes as seen in many vulnerable populations. Specialized training and education like this learning series are valuable tools moving forward to more accessible and equitable care for all communities. Next slide. So this chart highlights a few factors of SDOH impact. As mentioned, addressing SDOH is a primary approach to achieving health equity, such as poverty, unequal access to healthcare, lack of education, stigma, and racism, which are underlying contributing factors to health inequities. Understanding and addressing social drivers of health are crucial for developing effective public health strategies, reducing health inequities, and improving overall community well-being. By recognizing and acting upon these drivers, healthcare professionals, community leaders, and policymakers can work towards creating a more equitable and healthier society. Next slide. Roles of community partnerships in addressing social determinants of health. Later, you'll learn how collaborative relationships allow organizations to work together toward a common goal or purpose. You will soon hear from Lisa Guerrero, the community partnership manager at La Clínica de Pueblo, on how they built and sustained successful SDOH partnerships between their healthcare center and community-based organizations. Their successes, best practices, and strategies will provide tangible examples of how you might create and maintain valuable partnerships at your health center. From the slide, the partnerships can broaden opportunities to access services for special and vulnerable populations, allowing a more integrated approach to identifying and tackling SDOH barriers. Partnerships help accomplish goals, objectives that your health center may need to achieve. These partnerships will better serve our community by combining expertise, resources, and time when finding funding resources for new programming or when services are limited. Next slide. As mentioned before, partnerships will help us accomplish goals and objectives we could not do on our own. Partnerships can help us expand knowledge, skills, expertise, increase resources that are money, time, staff, etc. Improve visibility of the cause or goal, and expand your reach and reach a broader audience. Next slide. The role of community partnerships can play in addressing social determinants of health are when wanting to increase access to healthcare, collaborations with CBOs or other health facilities are needed to improve access to healthcare services, such as mobile health clinics, interpretation services, transportation vouchers, etc. To provide access to education and training programs, collaborate with educational institutions and CBOs to design, deliver educational programs that address health challenges. Also, partnerships with community empowerment and advocacy with local leaders, stakeholders can facilitate increased community engagement, education, and capacity building initiatives to support the well-being of patients. Soon you'll hear from Yasmin Tarver, Director of Workforce Development in the Jessamine Center community on the importance of organizational legal partnerships and housing partnerships that have contributed to a more equitable approach to healthcare by addressing the social drivers of health and how integrating legal and housing services into health center programs, communities can experience improved health outcomes, reduce healthcare costs, and overall well-being. All health centers and communities vary depending on your location, but I'm still sure many of you can think of health facilities, education institutions, or CBOs in your area that could be potential partners. Our presenters today are Lina Guerrero, a community partnership manager at La Clínica del Pueblo, and Yasmin Tarver, Director of Workforce Development at the Jessamine Center. Our first presenter, next slide, is Lina Guerrero. She has 10 years of progressive experience working in social development projects, operations, budget, and contract management roles. She's worked with stakeholders in public and private and nonprofit sector, as well as multilateral organizations and consulting. She's committed to advocating for positive social change by empowering vulnerable Latino communities and systems through co-creation and empathy. She's currently the community partnership manager at the Health and Equity Department of the La Clínica del Pueblo, where she fosters community participation in program development and advocacy and coordinates efforts to strengthen community partnerships to address the most pressing social needs. Nina has a social enterprise master's degree from American University and a bachelor's in business and international development, also from American University. Nina migrated to the United States in 2004 and has worked as a consultant in social projects in Colombia, Mexico, and the United States. So without further ado, let's welcome Nina.
Thank you so much, Matt, for your introduction. And thank you everyone for participating today in this webinar. It's a pleasure to be here. As you said, I will be presenting today on how La Clínica del Pueblo is fostering intersectoral partnerships to address social determinants of health. So to start my presentation, I would like to tell you a little bit about La Clínica del Pueblo's history. In 1983, health advocates founded La Clínica del Pueblo in response to the emergent health needs of displaced migrants, mostly from El Salvador due to civil war and state-sponsored violence and repression. For many of these migrants, accessing healthcare services in the US was nearly impossible due to the cultural, linguistic, and economic barriers they had to face. In 1995, La Clínica was incorporated as an independent nonprofit, and then in 2007, it acquired the federally qualified health center status. We actually just last year turned 4 years, so we're really happy that La Clinica has been present for the community for this long. We are located in Washington, D.C. and Maryland. We have a clinical site in Columbia Heights, D.C., also a health and action center in Mount Pleasant, D.C. We have a clinical location in Maryland, and we also run several mental health school-based programs in public schools in Maryland. Let me tell you a little bit of the communities that we serve. So we serve around 4,500 patients each year. 92% are Latinx, 80% are immigrants, mostly from Central America. 35% are uninsured. 83% feel more comfortable speaking mostly Spanish. 84% have an income at or below 200% of the federal poverty line, and 20,000 have gone through community programming. So now I'd like to explain a little bit of our model of care. We use an integrated approach or wraparound services. We are rooted in the cultural understanding of the community we serve, and our work blends healthcare and social justice. So, of course, we have primary care services. We also have mental health and substance use programs. We have community programs inside this department called Community Health Action. And there are 3 programs. One is called Entre Amigas, that this is our gender and violence program. We also have Empoderate that serves the LGBTQ+ community. And lastly, we have the health promotion that offers prevention and treatment for chronic diseases. And the latest created department of La Clinica is called Health Equity and Community Partnerships. And that's the department where I work for. And I'll speak about this department later in my presentation. When we speak about immigrant health, we must talk about immigration status. So at La Clinica, we see immigration status as a social determinant of health. And why is that? So already Matt went through what the social determinants of health are. And we include immigration status because, as this image is trying to show, an immigrant already comes with many struggles that may be unemployment, stigma, discrimination, limited opportunities for education, and unhealthy and unsafe physical environments, lack of affordable healthy foods. And of course, immigration status is also another factor that excludes these communities to access social benefits. So these are some examples of the exclusion that the immigrant community, some of the immigrants have to face, and some of our patients and clients. So one very important is that many of them cannot access Medicaid. Any federal assistance program has many of them are not eligible to apply for it. So Medicaid, social benefits such as temporary assistance for needy families, SNAP, housing programs, and also jobs. That's why La Clinica decided, even though they've been in the community doing a lot of advocacy and giving voice to the immigrants that are excluded, they wanted to develop a department that could have resources to address some important barriers. So the Health Equity and Community Partnership Department has these components. First, it has the language access program. We have medical interpreters that navigate patients and interpret in their appointments throughout different hospitals in the area. We also have the strategic community partnership component. This part tries to centralize information on cross-sectoral network of agencies. So all of the organizations that La Clínica has a relationship with and that is serving us, we try to centralize this information and organize it and continue to foster these relationships. We also have multiple actions on advocacy, looking to increase healthcare coverage in Washington, D.C. and Maryland through policy change and coalition work. And we also work with participatory approaches, doing some research so that we can quickly identify urgent social needs that are affecting the Latino immigrants in the region. So I already talked about what La Clínica is, the history, the model of care, why immigration status is such an important social determinant of health. Now I would like to explain how community partnerships actually help us to address social determinants of health. So first of all, we began to use last year as a tool called Prepare. This is to screen patients. So it stands for the protocol for responding to and assessing patients' assets, risks, and experiences. And this is a national effort to help health centers and other providers to collect data needed to better understand and act on their patients' social determinants of health. An important aspect of Prepare is that it can be embedded in the electronic health record of the patient. So anyone in the healthcare setting can access not only, the physical health components and history, but also the social determinants. And this tool assesses things such as personal characteristics, family and home, so aspects such as housing status, neighborhood, money, resources, education, employment, insurance status, material security, and other aspects such as incarceration history, refugee status, safety, and domestic violence. So I would like to give you today an example of one patient that we had last year. After we conducted the Prepare tool, these are the results. So she is a Hispanic female. She's 78 years old. She's diabetic. She's unable to read and write. She's unemployed. She has a green card. She does not speak English and she's experiencing domestic violence. So I would like you to think about this person and think about how can community partnerships and wraparound services could help this patient. So one example is addressing social conditions through medical legal partnerships. As we know, and as already shown, immigrants have to face many struggles, right? They are excluded from the safety net and many social programs. So lawyers become very important in their health outcomes, and they become almost as important as a doctor, because they can also help them with things like eviction, utilities, accessing or any issues they have with utilities, divorce, any family matters, the ones that are eligible to access social programs such as SNAP, and also help them with their immigration status. So these type of partnerships have shown really positive impact on patients' health and well-being. These are some of the examples of the organizations that we have a partnership with. So Legal Aid Society of DC, Carecen, SEDEC, Ayuda, American University Washington College of Law, and Tahiti Justice Center. Another example of really key partnerships are the ones we have with farmers markets. So we are trying to address food security. So many people can go to the doctor and they tell them, okay, you have to eat healthy. But if they can't afford healthy foods, or they can have this sometimes luxury, then there is nothing they can do about it. So that's why we partner with farmers markets, so that we can provide fresh produce for them. So we have fresh product distribution. We also go to these farmers markets to do health screenings, for example, blood pressure, sugar, to find out if you're diabetic, get vaccines, and also they will get, we will have our promotores de salud, community health workers, providing education, answering any questions that the community might have. So these are actually really good partnerships for us. Another important aspect is that you should be assessing how your partnership is going. So we use a tool called Partnership Assessment Tool for Health, or PATH tool. And this tool will help you answer some questions to assess your strengths and your weaknesses and make plans to improve your partnership. Here are some important aspects to take into account for a successful partnership. First of all, it's important that both parties are accountable. That means that both La Clínica and our partners are really committed to solve the patient's issues. So we don't want to send people to other places that we don't know, because we don't want them to refer them to places that maybe do not speak the language, do not understand their cultural background. So that's very important for us that we get to know our partner, and we know that they are prepared for our clients and patients. So as already mentioned, language and cultural barriers are very important to assess before you do a partnership, an MOU. Also, our immigrant population, as you might know, they come to the US to work, and they have limited time. So some organizations might ask them to fill out forms, to go here, go there, and don't solve their issues in a respectful or in the best way possible. So we try to make sure also that we have a warm referral process, so that the patient feels navigated and feels that it can solve its issue, or at least they can get the information they need. And lastly, evaluation is always important. So as I already mentioned, we use the PATH tool. We also use sometimes satisfaction surveys. So this is a very important aspect, to be always thinking about the status and monitoring how your partnership is going, so that it's always successful. So I already covered community partnerships and why they are important, but there is another factor, which is policies. So as you all work in healthcare, I know you know that health is in all policies. So any public transportation, education, any other type of policies will have implications in health outcomes. And that's why policy is very important for La Clínica also. That's why we have some actions in advocacy. For example, we hold these events where we talk live directly with council members of Washington, D.C. and Maryland, and we explain to them the barriers to health that our community is facing. And we also host these dialogues for action that invite the academia, the people in the community, other agencies and organizations to talk about, complex issues such as displacement, such as housing and violence. So those are examples of what we do in advocacy. We will also give testimonies, provide testimony in the DC and Maryland legislature, and we also invite our patients to talk about the struggles that they face. So I hope you remember that I talk about this person that we screen. She's a Hispanic female, diabetic, unable to read and write, unemployed, etc. So I wanted to show you how with partnerships we were able to assist this patient. So first of all, because she has diabetes, we were able to provide a program through our health promotion program, where she can be signed up for physical activity sessions. She's also getting fresh produce through the farmers market partnership. And she's also attending healthy eating classes. Those services are, of course, culturally appropriate, and they are in Spanish. We were also able to refer her for legal services. So because she has a green card, she did not apply to the US citizenship because she doesn't know how to read and write. So this aspect is something difficult, because if you don't know how to read and write, you're not able to take the test, and then the person cannot get the citizenship. This aspect is something that we could take to advocacy and also work on it, because it's unfair that a person is excluded just because of this condition. So, but we will also refer her to get some advice on her immigration case, and also treat or try to see how she could address the domestic violence part through the legal system. And also we enroll her in the mental health program, the gender and violence program of La Clínica, called Entre Amigas, where she receives mental health services. And of course, we belong to many coalitions where we advocate for housing for domestic violence survivors, etc. So this is an example to show you how we address a patient with partnerships. And just to end my presentation here, this is a reflection from Pope Francis. It's a quote, and it says, "Migrants and refugees are not pawns on the chessboard of humanity. They are children, women, and men who live or who are forced to leave their homes for various reasons, who share a legitimate desire for knowing and having, but above all, for being more." Thank you so much for your attention, and I'm open for questions.
Thank you so much, Lena. So again, everyone, this is Bethany Hamilton from the National Center. Gonna leave Lena up for a moment on the screen and see if we can get 1 to 2 questions before hearing from Yasmin. And then we'll leave ample time at the end of the webinar today to take questions from all. So first, Lena, a question came in about funding supports for the partnerships with farmers markets. Do you have any examples of ways to fund that sort of partnership with the farmers market?
I know like some health departments, health agencies can provide funding for that. There's also private funding, and there's also other type. I can provide more examples. I'm not exactly sure, but I know there's a funding for that.
Mm-hmm. Great, thank you. And just one more question, and we'll make sure we save the rest for the end and come back to it. Another question: how do you help patients get to their appointments or services if they have very limited access to transportation or even the like the money to take public transportation? So any thoughts about how to help patients get to their appointments if they have very limited access to transportation?
I believe there are partnerships with Uber. Not exactly sure with what agency, but I know there's partnerships with Uber, and also in the DC area, fortunately, there's a good bus system. So also some people get metro help. So those are some examples of how they address the transportation issue.
That's great. Thank you so much, Lena, for taking a couple of questions there. We'll come back at the end because there are several other questions for you. I'm going to spotlight the next presenter, Yasmin, and bring up the slides again. Yasmin, we're going to spotlight you and bring up the slides, and it's all yours. Thank you.
Okay, good afternoon. Again, my name is, oh, I'm sorry, Matt, are you talking before me?
I can go. Yeah, let me give a quick intro to you. Sorry.
Okay.
Thank you. Yasmin Tarver currently serves as Director of Workforce Development at the Jenna Center, where she's responsible for identifying new partnerships, guiding the entrepreneurship, vocational and education, social enterprise, employment, and health education programs. The Jenna Center is a nonprofit organization that provides comprehensive, culturally competent, trauma-informed services to victims and survivors of domestic violence and their children. Yasmin has spent over 25 years as an advocate for unserved and underserved communities, holding positions on boards and committees that support youth, women, homeless families, education, housing, and health. Yasmin believes that the change happens when people are given the guidance they need to draw on their own strengths, thus realizing their potential to live fulfilling, happy lives. Did I pronounce Jenna Center right? Is that how it's pronounced? Wasn't sure.
Genesee.
Genesis. I actually Googled it and it told me Genesis. It was like the little sound was like Genesis.
Not
Anyway,
Google.
sorry, Genesis
It's
Center. Thank
okay.
you. Without further ado, here's Jasmine.
Right. Good afternoon, everyone. I believe it's afternoon. I'm in California, so when I started, it was morning. So it's a pleasure to speak with all of you today, and I'm going to explain a partnership that we started when we entered into the healthcare arena and servicing our clients and how we've expanded that. So next slide. So Genesee was founded in 1980 by and for women of color, drawing clients from communities where poverty is rampant, unemployment is high, educational attainment is low, and the housing market is the least affordable in the nation. And of course, we know it's become more unaffordable everywhere now. These factors make women more vulnerable to abuse and make it even more difficult for victims to leave. Genesee Center is one of the few DV shelters that welcome large families, families with adolescent males, and persons with one or more disabilities. In addition, Genesee houses those who identify as LGBTQ+, gender neutral, gender fluid, and we also have an immigration population. I wanted to note, because Lena went in expansive on her presentation, that we also have a full service legal department. And we believe that humanitarian forms of immigration relief is foundational. So we also provide help with U visas, T visas, VAWA, self-petitions, and battered spouse waivers. So Genesee services are provided in both English and Spanish and are free of charge. And DV survivors often have a history of chronic generational poverty. So among our clients, about 95% live below the federal poverty guidelines, and a staggering 92% report that they've experienced sexual or domestic violence. Next slide. So offering 43 years of life-saving services, we are a nationally recognized nonprofit domestic violence prevention and intervention organization. We work local, nationally, and globally to shine a light on domestic violence against women, girls, men, and boys. And we advocate for basic human rights for all people to have peace in their homes and relationships. Genesee's cultural sensitive programs and services not only transition families from crisis to self-sufficiency, but transforms the lives of its clients and community at large by offering education, referrals, and resources that go beyond shelter. Next slide. So we house women, men, and children from 30 days up to 2 years through our emergency and transitional shelters. We provide a variety of support, including mental health counseling, independent life skills classes, computer training, job referrals, after-school programs, field trips, tutoring, and the list goes on. I just want to announce that all of these are going to be available afterwards, so I might skip over some of it for the essence of time. So all of these services together is with the goal to model what healthy relationships look like and to work to break the generational cycle of violence. Next slide. So who do we serve? So Los Angeles is split up by city districts and supervisory districts. So we are in SPA 6, which is South Los Angeles, which is one of the most diverse and densely populated areas in the city of Los Angeles. And we are home to 6 federally subsidized housing projects. And you can see below, I'm not going to name them all of the communities that we serve, as well as we're in supervisory district 2, and that's how our county jurisdiction and has a population, of course, of over 2 million people as well. Next slide. So the people in our community. So our community is predominantly Black, African American, and Latinx. And so we have 63% of people who identify as Black and or African American, 3% that identify as white, 33% that identify as Latinx, and 1% that identify as other. Next. So our philosophy is based on the following values: that DV is a societal issue and it affects the lives of all people in society. Women and children are our primarily clients. Children are equal victims of domestic violence. That clients should receive culturally sensitive and culturally competent services. Shelter is only the beginning of intervention, and that clients must receive more than just shelter. They have to receive life skills as they re-enter into the world so that they can navigate that successfully. That we have to transform victims into survivors, that men have to be part of the conversation, and that services have to be provided to populations that are generally turned away from elsewhere, and that public opinion and public policy must be impacted to combat domestic violence. Next slide. So we have 5 signature services: family wellness, Generation J, which is our youth program, legal services, permanent housing, and workforce development. And I'm not going to go into all of that because you guys can see that on the slide at a later date. Next slide. So in California, statistics reveal that 40% of women have experienced DV in their lifetime. 10% of homicides are linked to intimate partner violence. 58% of residents have been touched by DV as either a victim, abuser, or through a close friend or relative. 40% of female homicide victims are killed by their current or former male intimate partner. And in Los Angeles County, 1 in every 28 households makes 911 calls related to DV, approximately 48,000 calls a year. Next slide. DV is a major public health issue, an important, often overlooked, significant social determinant of health, impacting 1 in 4 women and 1 in 7 men in the United States. And DV contributes to injuries, chronic health issues, high-risk health behaviors, and creates significant strains on the healthcare system and costs over $2 billion a year. Next. So in 2014, in the response to the prevalence of domestic and sexual assault and the profound health impacts of violence, the Blue Shield Foundation pioneered a DV and healthcare partnership. And 19 partnerships were created across the state with funding and an intending improving DV response through practice, policy, and system change in both healthcare and advocacy. Next slide. So of the sites, 4 particular based in Los Angeles County committed to changing systems in their own organization and then leveraging those lessons learned to promote systems change across their region. This cohort self-organized in 2017 to continue the work and promote DV and healthcare integration, thus developing the DV and Healthcare Leadership Council. Next slide. And that's the logo in case you've seen that anywhere. Next slide. So in 2019, we partnered with the Los Angeles County of Public Health to build upon and scale best practices and learning in order to improve these sustainable systems, to address the intersections of DV and healthcare across Los Angeles. And this partnership positioned the county to move beyond silos toward a collaborative framework for service provision, specifically addressing vulnerable communities. And now working through new and existing public health models, this work is advancing integrated care for DV survivors by sharing policy change recommendation and fostering, opportunities for capacity building and cultural responsiveness. Thus, we are promoting transformational systems change and intersectional approaches to marginalized communities that are impacted by violence throughout LA County. Next slide. So in Los Angeles County, a high percentage of women have experienced physical or sexual violence by an intimate partner in their lifetime. Yet statistics reveal that only 25% of DV cases are reported to law enforcement. Although many cases go unreported, many survivors disclose these incidents to their healthcare providers when asked about relationships. And we found in a recent study that 70% of patients want their healthcare providers to ask them about their relationships and intimate partner violence. Next slide. So what do we do? So Genesee Center leveraged and strengthened an existing and longstanding partnership with the Watts Healthcare Corporation to close the gap between DV and healthcare in South Los Angeles. Together, we implemented an innovative community initiative focused on improving healthcare response to violence and strengthening the way health and DV service providers interface to address health impacts in support of survivor health. And through this partnership, we were able to make lasting changes in the practice, policies, and systems to improve the provision of quality care. We streamlined cross-referrals that expedites access to medical and advocacy services and enhanced confidentiality policies that supports a feedback loop to track referral outcomes and overall strengthen community organizations' approach. So this was the model that we started and now have developed with a number of clinics and hospitals throughout LA County. Next slide. So I wanted to tell you a little bit about Watts. This is the mission of Watts and their vision statement and their values. And as you can see, they're also a federally qualified health center, and they have a number of other great designations that allow them to provide quality care. Next slide. And so I just wanted to say that they are proud of their history that spans over 5 decades as a leader in the community health center environment. They started as a volunteer-driven clinic that was birthed out of the Watts riots in 1965 to serving those most in need in Los Angeles County. And again, now they've grown to become a federally organized and award-winning healthcare institution. Next slide. So how do we do this? That's probably what you guys really want to know. So we had to create a framework to ascertain information and then how this is going to flow. So this is a diagram that shows we have a health advocate that's employed at the Genesee Center, and the health advocate, along with the nurse, does examinations and provides care for the people that come into shelter. And so when someone comes in, our family services department will make a referral to the healthcare advocate. And then they coordinate a time to administer an assessment within 48 hours of the referral. The advocate will complete the assessment, and depending on what happens, they will make the appropriate referral to a healthcare provider. So the health assessment is placed in their file, and a copy is sent to our data department so that they can track what's going on. And then we identify the clinic appointment was completed and also documented in the file. Now, we also have a monthly report of all health assessments that are kept, and family services contacts our health if this health advocate, excuse me, if the client's health status changes. So there's another form that we fill out that we ask basic information, and I did not have a clean copy, so I couldn't put that. But we're asking just basic determinants of health and questions about their health care. Next slide. So someone asked a very important question in the last presentation about transportation. And transportation was vital. And that was something that we had to figure out, because in the beginning, going from Watts to South LA, even though they're in the same district, could be about a 45-minute to an hour trip, depending on the day and the time and the method of transportation. So we actually worked with Watts. They had during the process of this whole collaboration, opened up an office that was closer to Genesee. So it was called the Crenshaw Community Health Center. And then we also partnered with California Hospital and Children's Hospital so that we would have a point of reference if something happened at a time that Watts was closed. So as you can see, we have someone, if they're walking or taking the public bus, if they're getting transportation through Watts, which we actually had a van that would sometimes provide transportation, taxi, and if they're driving. And so we gave very specific instructions, as you see. If someone needed 24-hour urgent care, we also gave them very particular. We had taxi strips, taxi vouchers. Now it's Uber, it's bus tokens, gas cards, depending on what the needs are the clients. And so this is showing the roadmap that everyone had at Watts, our clients, our staff. So there was a clear path of how someone could get to services. Next slide. So towards the beginning of this study, we provided the referral form to clients to take them to their healthcare appointment to inform people that, hey, we're here and that we're Genesee clients. And with the first month of collecting the data, we noted that this was not practical. So we met with the staff and we created a purple Genesee referral card that clients took with them to the appointment that had no identifying information, but all of the staff knew that they were a Genesee client. And our health advocate also would call our point of contact at the site to make sure that they made it, that they got the care that they needed. If there was any emergency medicine or other things that were needed, that we could follow up and make sure that was closed. This amended protocol allowed both organizations to track the client and the patient, their treatment, and collect that data and to make sure that they were getting the care. One of the other issues that we ran into was that many of the clients were uninsured or either had out-of-network insurance. Next slide. So we had to address that. And so what we did, and I'll talk a little bit about how we addressed those that didn't have insurance. Another challenge that we faced was navigating staff discomfort. Some of them had a lack of confidence in discussing about DV and health and doing routine assessments in a clinical setting because they came for something else. And so they want to treat, of course, what they were presented with, not what maybe came ancillary out of the conversation. And so we found that staff welcomed the new screening processes that we were trying to teach them, but it actually came down to implementing interventions and the cultural barriers and the unfamiliarity with the new terminology. And we also felt at times that, and they communicated to us that they were overwhelmed because now there's new papers and there's limited time and we have to keep a schedule. And so we troubleshooted these barriers by embedding a train-the-trainers model, and we worked to allow designated champions at each site to contribute to training additional staff. Next slide. So we worked diligently to enroll uninsured people into various insurance programs. And so when we had a client that we couldn't get insurance right away, within the first 72 hours of entering our program, Watts worked with us to provide a courtesy appointment to our clients that were out of network. So this allowed them to still be seen while we worked alongside to get them insurance. Next slide. So we conducted ongoing trainings to over 300 healthcare and DV staff members and linked over 750 DV clients to medical services at Watts Healthcare Corporation during this time. We felt that we promoted the best practices and partnership development to over 200 people in the field. And as I said that, Genesee now has engaged in several new partnerships to expand the services. Next slide. So the key finders is that we found through this is that healthcare providers are twice as likely to screen for DV. They doubled their rate of assessment of DV during clinic visits, and 2 out of 3 patients reported having their provider talk to them about healthy and unhealthy relationships. Patients are more likely to report DV, and DV survivors are more likely to focus on their health needs. Next slide. DV advocates and health providers are more likely to make referrals, and both advocates and healthcare providers reported significant increases in their confidence of being able to assist the people that were coming through the doors. And the access to care was significantly improved through the coordinated systems of care. And 100% of the survivors who tested positive for STIs were treated and completed all of their follow-up visits within 3 months of post-screening. Next slide. So what we learned is that the true success of this partnership is the invaluable feedback that we received with clients with their unbiased opinion. And there were positive comments on the wait time and how they could see a healthcare provider, the friendly staff, and the expectations that they felt that had been met. Next slide. And that partnerships take time to cultivate, and champions ensure their growth, and DV programs are well positioned to move the needle for change towards prevention and better healthcare advocacy and better survivor outcomes. But we want to say that this work takes time, and partners have learned that successful change over time is attributed to identifying organizational champions, and that champions drive partnership development. Next slide. So it was a mutual beneficial partnership. It addressed the needs, it provided a referral process, and the unique aspect of this was pivotal in our success as we were able to create non-urgent appointment times that were set aside for Genesee clients, and that the staff from Watts Healthcare worked really hard to accommodate our clients. Next slide.
Is there a link?
Okay, I need a friend. I need a friend.
Okay, next slide. So next slide, we'll pass through that one. So I wanted to tell you just really 2 quickly client stories. Next slide. So client H arrived at our emergency site after fleeing her abuser, and she was he told her when she was leaving that she was HIV positive. So she was worried that she contracted the disease and was having a hard time adjusting being in the shelter. She explained that she wasn't knowledgeable about DV and transmission, and so she had been hesitant to interact with her son, which was a newborn, until she knew her status. Next slide. So we were able to gain an appointment to have her have HIV testing within 1 day of explaining her situation. And after receiving a negative result, she expressed how grateful she was for assistance in gaining an appointment and the relief that she felt knowing that her status. And so, of course, you have to continue to test. So we worked with her to continue that testing process. And each time that she went, she tested negative. Next slide. This client, she was a mother of 5 children. She fled from her abuser after being attacked by him and members of his family. She was evaluated and she was confident that her children had not been in any direct effects of sexual or domestic abuse. However, days after entering our program, the client's young son had an evaluation, and we found out that he was actually a victim of DV trauma and sexual abuse. And this was a very fortunate situation for this mother. However, she was able to become aware of the severity of the situation and opened a dialogue and a treatment with her and her other children. And we were able to provide not only physical health services, but mental health services to help the family achieve an understanding of what happened. And to receive continued counseling. Next slide. So I'm not going to go through all this because of the essence of time, but I just wanted to say that ongoing staff training, assessment, and response has to be prioritized, and that training has to be ongoing and accessible for all staff and integrated into staff that you're onboarding. Next slide. that we know that patients don't often disclose out of fear of judgment and repercussions, and that sometimes advocates don't ask survivors because they're not aware of the health impacts of violence, and they don't feel like they're adequately educated to discuss the medical needs of clients. Next slide. Barriers are important. We have to take time to explore and understand the barriers. And we have to talk about this and have these honest conversations, and sometimes uncomfortable conversations. Next slide. Partners, programs, and growth. We have to navigate, put systems in place, develop champions, schedule staff, embed new practices. That's the only way that we're going to create capacity and adaptability. Next slide. And then, the experience of violence is prevalent, and it affects all of us. And we have to understand that sometimes the staff that are treating these people also have evidence of domestic violence, and that came out too. And so we had to get counseling for the people that were actually serving the people. And so with that, we had to develop a workplace response to violence, and we provided counseling, crisis, and some of the staff members ended up coming into shelter as well. Next slide. And so partners are sustainable and they do work. Next slide. And where do you start? You don't have to be a DV expert. You can build partnerships with family serving. You can lean on expert partners. DV support services are a critical part of our healthcare infrastructure. Next slide. And this is how you can start. Learn about your resources, identify champions, establish MOUs, engage in cross-training. You can start small. You don't have to have all the pieces together. You just have to start. Next slide. And then just DV is a comprehensive issue, and it impacts a victim survivor's life in every capacity. And oftentimes seeking evaluation by a healthcare professional is delayed unless there are visible signs of physical trauma. So we just have to understand the stress of the situation, that it has long-term health effects, high blood pressure, chronic stress, ACEs in children, and developing relationships between organizations and healthcare providers have to be in place to address these needs. And through this partnership, it was very instrumental in addressing health concerns and allowing for preventive medicine and family planning that had great outcomes for the victim survivors and their families. Next slide. And this is how you find us. We're on social media, and my email address and our 24-hour hotline. And thank you for your time. Sorry, I had to go through it pretty quickly, but again, all of the slides I believe will be sent to you. And so you can dig a little deeper and pick up on anything that I missed. And of course, if you have any questions, you can ask now, or you can feel free to email me.
Yasmin, that was excellent. Thank you so much. A lot of rich content, and I know both you and Lena have a whole lot more to share and highlight about the great work that you're doing. A question that I'll pose that came in from the audience for you is as follows. This person shared that they work with housing homeless clients, and some of their clients are DV or experiencing DV. Or had experienced DV, whose information is not completely shared due to security reasons or confidentiality policies in place at the agencies that serve to protect and provide services for individuals experiencing DV. So that makes it really difficult to then record data and systems such as HUD's Homeless Management Information System. Do you have any suggestions with regard to solutions for working to overcome some of those barriers and still be able to provide holistic care?
Yeah, so Genesee and homeless services, the DV service providers in Los Angeles County, we do not enter into the HMIS system. So we have a different database, and what we do is we have a unique code that identifies the client. So it doesn't give their identifying information. And so again, with Watts, we had a special card that we sent to Watts. And so between the people at Watts and the people at Genesee Center, we were able to confidentiality was in place, and we were able to share the information to get them their care and to protect their confidentiality and safety.
That's great and super important. Greatly appreciate the individuals who are asking about those questions about how to protect the patient populations that or client populations from becoming even more susceptible to the dangers that persist around us. I'm going to ask if we could also spotlight Lena so that we can pose a question to both Yasmin and Lena. I think it's relevant to both of you. And it was posed a little earlier. It's asking about the, I'll wait for us to spotlight Lena so she can come on the screen. In the meantime, I'll pose the question. Thank you. So here's the question. What is the framework for how your organization tracks and follows the outcomes of referrals to legal aid? For the either legal clinics or referral systems or a full MLP, a medical legal partnership, how are you tracking the outcomes of those referrals to legal aid?
So at La Clínica, we developed just like a simple form with Microsoft Forms. And this is filled out by our care coordinators or any health educator, anyone that needs a request. And they will submit it to me. And then I can contact our legal organization. I have a point of contact there. They can enter also the form because we share Microsoft, so they can also enter and see the information, or they get a notification that the form was filled out, and they will review it, tell me if there's any other information needed, and if everything is fine and if they qualify for the service, then they will be referred to the lawyer. And yeah, that's how we do it at La Clínica.
So at Genesee, because we actually have a full service legal department, and I didn't even get to say that we have a functioning legal clinic inside of the Inglewood courthouse, and we process restraining orders and other things for clients. We do a lot of our work in-house, but we also have a number of partners and we participate in a number of pro bono clinics. And so we have a database as well, because data is very important, and data is really important for survivors and victims of DV immigration status, because this information is not readily available. So when it comes to funding and other things, we have to prove why this money is important. Right now, when we're dealing with VAWA cuts and all of these things, these are foundational, these services, these critical life-saving services for a lot of organizations are in jeopardy because the funding is being taken away and people don't understand that. So this is where the data comes in, where we're talking to our congressional leaders about why this money has to be put back in the budgets, because if you don't, then we're not going to be able to help 1,000 people process a restraining order a year. And that is that for the community. Anyone can walk into the Inglewood courthouse and get a restraining order. It doesn't have to be specifically a Genesee client. They might end up being a Genesee client, but literally it's a community resource that it sometimes could be at jeopardy because of some of these cuts that are coming up.
Mm-hmm. That actually provides a great segue to a conversation that was occurring in the chat, and also some of which was formed into questions that came in Q&A. So a lot of folks were curious to learn more about Z codes and how those, how often, how prevalent are they being utilized for the collection of social determinants of health related data and services. And then can it lead to funding? Any quick thoughts, Lena or Yasmin, on how folks can really leverage Z codes and how it might be able to lead to strengthening funding for these interventions? I'll also
You want to go
know.
first, Lena?
Thanks, Yasmin. Yeah, go. Either one of you are welcome to take a stab at that.
Well, I know La Clínica had this Z codes, but there was like an issue with the insurance programs. Like there was a problem with the Z codes that we couldn't continue to use them. So yeah, I don't have enough information.
Lots of room for improvement for everyone on Z codes.
Yeah.
That's for sure, Lena. You're not alone there. And Yasmin.
Yeah, so for at Genesee, we actually have a mental health department and we have the clinicians. So they're able to, how do I put this, eloquently decipher that code to make sure that we get the clients the services who they need through the Department of Mental Health, the Department of Health Services, and stressing we are moving into the world of how to and this is a whole different conversation, to navigate Medi-Cal services, because we're doing a lot of those intensive case management service to make them billable services that can support the clients that we serve. But that's a whole nother ball of wax that we're starting to enter to as a DV organization. But really, it's at the local level and communicating to your departments of public health or health services or whatever they're called, the needs that your clients are presenting and the services that you're providing them, and how can we meet that funding gap, or how can we increase the funding for that particular service.
A couple of people greatly appreciate that, Yasmin and Lena. Folks have been sharing some really great resources on this related to Z codes and billing challenges. Even the billable provider also matters. But we're making some progress in that space as well. In the meantime, though, agree with you, Yasmin. The data matters for all of these services to be able to show and demonstrate the impact of the funding dedicated to them. The next question is, are there modifications that you use for your DV patients? Yasmin, I believe this question is for you. Are there modifications that you use for your DV patients in the EHR so that certain information does not flow into the patient portal?
Yeah, so it's a unique identifier. And so we go to the links that, like, if we have to communicate with a client, about a client through email, and the client's name is Mary Ellen James, it's MJ. We don't use full names. We use client codes. We use the phone a lot sometimes because we're sharing information that, we don't know where batterers work. And our thing is, batterers can work anywhere. Someone can have a connection to anywhere. So information is, not safe. And it's not that someone's intentionally trying to find someone, but sometimes they are. And so really using that unique client code, -2 JR, whatever your agency develops, is very essential, because that is the barrier for their confidentiality. And that least giving as less identifying information as possible, the information essential to their treatment and care, and only that.
That's key. That's a great best practice for folks to take away. Thank you, Yasmin. Lena, a question for you about the access to food. So I'm going to attempt to combine two questions that came in about the farmers market again. Number one, do the patients get the fresh produce at the farmers market or at your clinic? So a little bit more information about the logistics. I think it goes to, some of the questions that also came in about the transportation barriers or timing, perhaps, for when food distribution occurs or when the food pantries are open. That would be helpful. So do the patients actually get fresh produce at the farmers market or through your clinic?
So we do both. We go to the farmers markets and we do the distribution there, because the community gathers in that place already. It is really well located. So we take our health promoters and we take our staff and we do the distribution there, and we also do it at our clinical site and our community center site. So we try to provide it everywhere that we can. And about the transportation, actually, we are in the DC area and it's not that difficult, the transportation part for our clients. Maybe people that live more in the suburbs, of course, it's difficult, but fortunately in DC, the transportation part is not that hard. So we are able to have people come either to the farmers market or to the clinical site.
And then the follow-up to that is, are you tracking referrals such as to the farmers market, as well as any barriers that were addressed, like the transportation or housing need along with it?
Yes, we track. So we are in the phase of implementing Prepare, but each program has their own intake form, and they have because these are also money from grants that require reporting. So we have to track everything.
Mhm.
So yes, we do track the amount of people that get fresh produce, that go to our classes, everything is tracked.
Right, so that data matters. Once again, that
Yes.
data always matters for whole person care. Thank you, Lena.
Mhm.
I'm gonna go with a question that came in that either of you might want to take a stab at here. The question is, going to do my best here. How can we ensure or guarantee community engagement continuum? So, what are some of the elements that we may want to ensure that we consider when creating that continuum of community engagement?
We
Elements or processes?
community engagement, we do it in many ways. So from our side of partnerships, we hold these events that we invite our community to tell us, for example, what are the barriers they're facing. We also have a comité de pacientes, a patient health committee. We gather them like every 2 months, and the executive director comes and listens to the concerns of the community. We are also been in the same place for 40 years, so we are very, people know La Clínica really well, so they feel this is very important, trust of the community, especially immigrants. They are already afraid of asking for help. So for us, it's important that they feel in a trusted environment. So we try to hold everything very culturally appropriate. We celebrate, Dia de Muertos. We celebrate all these traditions so that people feel actually welcome to our place. We don't have like this fancy building that people are going to be like, I don't want to enter there because it reminds me of a government immigration center or something. So we try to make them feel very welcome, and we go to health fairs, we go to churches, we go to farmers markets. So we are in every place possible, so that people, feel like Clinica is not only a place that you have to go to, they are in the place that people are already going. So that's our strategy to maintain this community engagement, and always, ask them, like, get to know what is going on, because if you lose sight of what is happening in the community, you're not able to really help.
Serve them. Yeah, agreed. Meet people where they are. Lena and Yasmin, you're both in very urban areas. And so for the folks who are tuning in or will view this training event and are in more rural areas of the country, any tips based on your experiences for how they might want to begin building and developing more holistic or whole care partnerships to address those social needs of their populations?
I would say,
Yeah.
oh, go ahead, Jasmine, because I already.
Okay. I would say, going back to the grassroots, since it's, the fortunate thing about that is your community is smaller. And so you're able to provide more intensive outreach and services for those that are interested. And so I would just say making sure that the community knows that you're there. And domestic violence is difficult. No one wants to tell anyone that they've been abused, okay? And people are now learning at adulthood that they've been a survivor of domestic violence because it was a mental health issue, a financial, a sexual, a reproductive, a religious. It wasn't physical, but they're coming to terms that somewhere along the line they either knew someone, know someone, or was in a direct effect of domestic violence. And so as people start to unpack that in their brains, they're wanting to find out more, and they're saying, I wish that I knew, or I wish that this was there for me so that I could get help. So word of mouth actually is one of the biggest carriers in this, because people don't want to talk about this out loud. This is they're whispering or they're texting about it because they're embarrassed. Okay. And so just having services there, we do a lot of stuff with corporations, with churches. We have a whole outreach department to go around to people. And so we're, like she said, we're in a bigger area and we can get that done. So the ability to have a smaller encashment area just makes the outreach and the connection more richer, because you can invest in a smaller area that probably, is scared. That could be an issue too when you're in a small community. Everybody knows if I'm going to go. And so there could be hesitation and fear, because, somebody saw her walk through the door and so she's abused, and they're talking about it at church and work. So really supporting people and knowing it's safe and it's a safe space and it's going to be confidential when you're dealing in those smaller areas is super important. It's important everywhere, but super important where there's like a microscope, where there's just one building, one church, everybody knows. And so you really want to protect people, and that's the only way you're going to get them to get the help that they need and deserve to have to heal.
And I will complement social media, promoting your services through social media. It could be cheap and a way that you can reach out to communities that maybe are not able to see you or see your location. So I think holding, posting videos and information on how to access like a phone call for us in Latin America, WhatsApp, like we use WhatsApp a lot. So those tools that can help you, like maybe as you were saying, maybe it's not safe to walk to the place because they're going to see you, but if you have your phone, that maybe you can, use a text message and a WhatsApp group, stuff like that, that can help you access some resources. And also the tool, the prepare tool is also very helpful, because if someone comes to a doctor's appointment, and when they're completing the assessment, they say yes, domestic violence, then they can be referred to our program of domestic violence. And they don't have to say, oh, I mean, they just have to say, I went to the doctor, and they don't have to mention anything related to the domestic violence program. So it could be another way that you can like quickly find out that the person is maybe going through some violence, and refer this patient to our domestic violence program.
And just really quickly, Bethany, we created an app, actually. It's called Gen for Hope. And so you can go on our app and you can ask questions, there's videos, and you can actually reach out and schedule an appointment. You can actually call 911 if you're in need of immediate help through the app. And so we tried to reach people who non-traditionally have their phone is everything and they need assistance and they're just trying to figure it out. So I think someone just popped up. It's called Gen for Hope, and it's on the App Store and the Google Play.
Google Play. I think you're right.
Google something.
These are great. And Gen for Hope, we'll type it in. Yasmin will see if we can share it as well in a follow-up email with all of the registrants. I want to combine some questions that came in all of a sudden in a flurry that are really interested in the legal aid component of what both of your health centers are able to get done. And they really focus on I'm doing my best here because a lot of them came in all at once here. I think folks are really interested in how that legal aid organization or the legal services provider follows up with you. So if there's like a really succinct way of sharing, I think, how you ensure you're receiving information back, that might be helpful. Yeah, let's start. Yasmin, do you mind if I pose that one to you?
Sure. So yeah, so we, have a check-in with all of our legal department meets weekly, and they talk about, the pressing cases and those cases that I say extend out of Genesee, which they might be in the court system or might be with another higher level in, a specific set of legal services that we can't provide. And so we're in constant communication with everyone we work with, from the point that it opens to the point that it closes. So there's a continuous feedback loop that goes on with our legal services department. We now have a department of 12, including staff attorneys and paralegals, and and advocates. So we're really able to focus in and make sure that we have the time and attention to give each client who's presenting certain legal issues the concern that they need, in addition to a whole other team that's at the Inglewood Courthouse. So just our in-house tracking system and meetings between the staff and the partners that we work with.
Thanks, Yasmin. And then Lena, are you all using, and Yasmin, but I'll start with you, Lena, are you all using an actual intake form to help track the referrals as a part of your process?
Yeah, so like first of all, Jasmine, this is our dream to have in-house lawyers will be so cool. Because you know we have to find these partnerships because we don't have the we can't afford to have lawyers in-house. But yeah, we do track as I was saying, we use Microsoft Forms, and that will give us, you know, an Excel tracking. Is nothing sophisticated. It's like an intake form, and we monitor through that.
Awesome. Awesome. I still know folks who are using intake forms on paper religiously, and they work just as well as having the integrated EHR. They've made it work for what resources they have, and they sure, everyone's dreaming about the gold nugget or whatever that is for that community. But Yasmin, I think that goes to what you mentioned to the audience about, you know, start small, that gets you
Yeah.
to start somewhere.
Yeah. And with COVID, we had to pivot. Remember,
Yes.
we were still open and we were still serving people. And so we had to build things electronically that were safe and secure through DocuSign and I'm sorry, I don't remember the exact website that our legal services used that was confidential, and making sure that people were protected, because as most of you know, the pandemic exacerbated all of these situations for us. So we didn't have the luxury of working from home, and it was boots on the ground trying to figure out how to help these people and deal with an environment that, you know, we all didn't know what was going on in the world at that time. So we also created online confidential assessments and stuff to be able to still serve people. In addition, the court system for a while was online. That's one of the great things. Now, a lot of our clients can go online to handle some of their smaller issues, and that removes the barrier of having to see their abuser in court, or intimidation and other factors that were used before. So that has been a great thing that has come out of the pandemic, that this can be done. And before it was like, no, that's not possible. You can't do that. That's not legal. But they found a way. And that's one of the great things that stayed after all of the pandemic supports left.
Last question, and then I'll pass it back along to my colleagues, the other NTAPs who helped to organize today's event for SDOH Academy. Lena, I believe this one is for you. But Yasmin, apologies if I got this wrong. So the question is, can you clarify if taxi vouchers or the Uber partnerships are grant supported initiatives, or are they a part of the regular operating budget? This might help get people a little bit more context about how you're able to actually meet those needs.
So I think I forgot to mention that Medicaid does cover the patients that have Medicaid cover when they go to doctor's appointments. They can be charged to Medicaid. And as I was saying, like, transportation is not such a big issue. So I know, like, we had a partnership with Uber, but I'm not sure. I don't have exact details on if it's a regular thing. I don't think so. I know mostly because it's not such a big problem. We have Medicaid covering the patients that are eligible. They can charge it to the Medicaid bill.
It's great. It's definitely worth an inquiry with the ride share. Yasmin, do you want to hop in before I close?
Yeah, that's the same. And also we have organizations that support taxi vouchers, and you know, California, specifically Los Angeles, has done great to make the metro affordable. So we can apply for certain programs that they can get low or no cost rides if they're using the bus or the rail. And then with Uber and Lyft, it goes and it comes. You know, for our workforce development, people can get free rides to an interview. If there's an emergency situation, of course, we're going to pay for them to get to where they have to go. So that's a non-starter here. But yeah, just writing to Uber, writing to Lyft, and explaining your organization and what they're doing, and to see how they can support you, especially if you're a small nonprofit organization. It's really about, again, building partnerships and letting people know what you're doing and asking them for their help. The worst thing they could say is no, right? But they can also say yes, and that'll make your life a lot easier. And I always tell everyone, when we're partnering together, we're going to make each other both look great, and we're going to do something phenomenal and groundbreaking. So why would you not want to be a part of that? And usually that works.
Awesome. That's awesome. It was music to my ears, as well as our audience and the folks that work together on SDOH Academy. Yasmin and Lena, we want to sincerely thank you for joining us today and sharing your experiences, expertise, and knowledge with the audience to really help us all better understand how to build these partnerships to address those social needs and risks that health center patient populations and communities face. I want to also thank the audience for sticking it out with us. The recording and the slides will be online, but you'll see once we do share the slides that there are additional curated resources that are focused on building those SDOH focused community partnerships. In the chat, you'll also see, and we'll continue to share, a link to our evaluation. Please fill it out so that we know how well we did and how much we can continue to improve. And we certainly hope you all will join us again on March 14th for the final webinar of this 4-part national webinar series. We promise we'll get the tech all fixed and figured out, at least. I don't know about fixed, but figured out, so that folks might be able to join us just on Zoom on the final webinar. Again, Yasmin, Lena, and SDOH Academy faculty friends, thank you all for this wonderful webinar. Audience, we'll see you next time. Everyone have a great afternoon. Bye-bye.
Thank you. Bye.